Welcome to the Immunology Serology lecture on influenza, measles, mumps, and rubella. Most respiratory infections are caused by viruses. Like their bacterial counterparts, viruses are categorized as either upper or lower respiratory tract pathogens. Viruses that commonly cause both upper and lower respiratory tract disease include influenza, parainfluenza, respiratory syncytial virus, or RSV, and the SARS coronavirus. Viruses that commonly cause lower respiratory tract disease include rhinovirus, non-SARS coronavirus, and adenovirus. Which of these viruses do you think causes the common cold? The answer is parainfluenza, rhinovirus, and non-SARS coronavirus. Most historians credit Hippocrates as providing the first written record of influenza. In 412 BC, he described an influenza-like illness he called fever of Perinthus, after the port city of the same name where the illness occurred. The word influenza, though, wasn't used to describe the disease until about 1357. People called an epidemic in Florence, Italy, influenza di freddo, which translates to cold influence, a reference to its possible cause. The first description of the early symptoms of influenza date back to 1664. So as you can see, influenza is a disease that has plagued humanity for several millennia. Many pandemics have also occurred throughout history. The pandemics of 1889 and 1957 resulted in around 1 to 1.5 million deaths each. Those are relatively low numbers, though, when compared to the pandemic of 1918, which caused somewhere between 20 to 100 million deaths. This is a photograph of an emergency hospital at Camp Funston, Kansas, during the 1918 influenza pandemic. This diagram depicts the major structures and components of the influenza virus, including its genome, capsid, envelope, and major surface antigens. Two of the most significant surface antigens associated with the influenza virus are hemagglutinin, abbreviated HA, and neuraminidase, abbreviated NA. Hemagglutinin is a viral surface protein that serves as a host cell surface protein receptor. It allows the virus to attach to host cells and is the first step for it to gain entry. The name hemagglutinin comes from its ability to agglutinate RBCs in vitro. Neuraminidase is a viral surface protein that is an enzyme. It assists with viral fusion to host cells. It also catalyzes the destruction of the host cell membrane to facilitate the release of newly made virus particles. It's worth noting that all neutralizing antibodies produced by the immune system are directed at hemagglutinin and neuraminidase in vivo. As a side note, there are two membrane proteins that are not shown on this diagram called M1 and M2. Neither one changes much, so a universal vaccine might be constructed against them. Viruses are classified in part on the composition of their genome. The influenza virus is classified as an RNA virus and belongs to the family Orthomyxoviridae. It has a segmented genome consisting of 8 segments. There are three major serotypes of influenza. Actually, there are four, but the fourth one doesn't cause disease in humans. The three serotypes are A, B, and C, with serotype A causing the most severe infections. Viruses are continually changing as a result of genetic selection. Major genetic changes occur through recombination, a process termed antigenic shift. By contrast, antigenic drift results in more subtle changes and occurs through mutations. A mutation occurs when an error is incorporated in the viral genome during replication. For the influenza virus, antigenic drift occurs due to mutations that affect the hemagglutinin and neuraminidase, or HA and NA proteins. It tends to occur every couple of years for type A, and even slower for types B and C. Generally speaking, antigenic drift occurs more rapidly than antigenic shift. There is not as wide of a variety of hemagglutinin and neuraminidase for influenza type B and C when compared to type A. If two different strains of influenza type A co-infect the same host cell, they can swap segments of their genome following replication to generate progeny viruses with novel genome combinations. This process is termed gene segment reassortment, or simply reassortment. The result is antigenic shift and production of a new, novel strain of influenza type A. Reassortment is an evolutionary mechanism that is exclusive to the influenza virus and other segmented RNA viruses. It plays an important role in the emergence of a new viral strain and interspecies transmission. For example, human and animal influenza type A segments can undergo reassortment. As you might already suspect, antibodies to previous strains are not effective, and this is why you have to get a flu shot every year. By analyzing the genome of influenza viruses from prior pandemics, it has become clear that antigenic shift, or reassortment, is the underlying cause. And by the way, only type A can undergo antigenic shift. Parainfluenza, by the way, is non-segmented. I know I already mentioned some of the characteristics of hemagglutinin in neuraminidase, but here are a few more. Hemagglutinin, or HA, is a protein, and more specifically a glycoprotein, that is expressed on the surface of the virus. It sticks out from the virus and facilitates attachment to select target cells bearing sialic acid residues, such as the epithelium of the respiratory tract and red blood cells. Once attachment has occurred, hemagglutinin also causes the virus to enter the cell. Coincidentally, or not, it is called hemagglutinin due to its ability to bind red blood cells, causing agglutination. Neuraminidase, or NA, is an enzyme that also sticks out from the virus. Its function, though, is to cleave sialic acid from glycoproteins, enabling the virus to be released from the host cell. Influenza is transmitted by infected aerosols and droplets. The virus typically enters through the eyes and respiratory tract, particularly the nose. This is an obvious indication of the necessity to cover one's mouth and nose when coughing or sneezing. The aerosols generated from coughing and sneezing can be spread within a 6-foot perimeter out from the infected person. Studies have shown that these aerosols can travel and stay airborne for a long period of time. Most experts think that flu viruses are primarily spread by aerosols made when people with the flu cough, sneeze, or even talk. These droplets can land in the mouths or noses of people who are nearby or possibly be inhaled into the lungs. Large droplets can contaminate surfaces, spreading the virus through fomites. If an infected person has had recent contact with a fomite, and an uninfected person comes into contact with it and then touches their eyes, nose, or mouth, they can become infected. Use of an N95 mask will provide adequate protection from exposure. The typical flu season in Oregon is from December through February, though it is not uncommon for cases to develop 1 to 2 months on either side. Flu can spread rapidly through the community, often within only a few weeks, and is capable of infecting upwards of 10% of the population. It is not uncommon for up to 30% of school children to be affected. The typical incubation period is between 2 to 3 days, followed by an abrupt onset of symptoms. The symptoms include fever, chills, headache, and myalgia. The symptoms are due to the body's immune response. Production of cytokines and interleukins, called a cytokine storm, are designed to kill invading organisms. The virus is excreted 1 day prior to onset of symptoms, but can be prolonged in children. People with the flu are most contagious in the first 3 to 4 days after their illness begins, but this can be as long as 7 days after becoming sick. Children and some people with weakened immune systems may pass the virus for longer than 7 days. Maximum severity is typically experienced within 12 hours from the onset of symptoms, followed by development of a dry cough. The severity of symptoms tends to be proportional to the age of the patient, the exception being infants and the elderly. Influenza type A and B cause the most severe infections. Type C is much less severe. Symptoms are similar or can be the same for type A and B. Recovery generally occurs within a week, but the symptoms of fatigue, weakness, and cough can last for several weeks. Cases of influenza can sometimes progress to viral pneumonia. This is what happened in the 1918 pandemic. This situation can set a person up for a secondary bacterial pneumonia, both of which can lead to death. The virus destroys the epithelial cells in the nose and sinuses, which are important defense mechanisms for the respiratory tract. Antibody production peaks within 2 weeks of the onset of symptoms. Antibodies against hemagglutinin provide the most protection, helping to prevent reinfection by neutralizing the virus upon re-exposure. IgA antibodies are likely the most important here since they are present in mucous membranes. Antibodies to neuraminidase prevent release of new virus particles from host cells. They are not as protective as anti-hemagglutinin antibodies, but may help to limit viral spread within the host. Alveolar macrophages and cytotoxic T cells, both CD8 and CD4, provide the primary cellular response. When it comes to diagnosis, symptoms are not definitive, but they do give an overall clinical picture. There are 2 levels of testing for influenza: screening and definitive or confirmatory. Most screening tests are designed to be performed at the point of care. They are cheap and quick, generally results in around 15 minutes. For definitive results, the gold standard is cell culture. Although this is the gold standard, it is not routinely performed. The turnaround time is around 14 days and is rather labor intensive. Currently, molecular methods such as PCR are much more common to use. Results can be achieved in as fast as 1 hour. Testing for influenza for the purpose of monitoring the course of the disease is not routinely performed. This is a table expressing the mortality in America and Europe due to the flu pandemic of 1918. This table, published by the Oregon State Public Health Lab, detailing the percentage of emergency room visits for influenza-like illness from 2016 through 2019. The majority of screening tests for influenza, such as lateral flow tests and ELISA, are based on viral antigen detection and are usually CLIA-waived. We will discuss the lateral flow test further on the next slide. True diagnostic tests, such as RT-PCR, which stands for reverse transcriptase polymerase chain reaction, are not CLIA-waived. The typical specimen required for testing is a nasal swab. Remel multimicrobe media, or M4, is the primary transport media for Legacy laboratory services. Legacy will also accept these other transport media for reverse transcriptase PCR analysis. Copan Universal Transport Media, or UTM-RT, BD Universal Viral Transport, Cepheid Expert Viral Transport Media, and BD Universal Viral Transport for Quest Diagnostics. Results can usually be obtained within 1 hour from receipt in the lab for emergency department specimens, 6 hours from receipt in the lab for inpatient specimens, and 24 hours for outpatients. Antibody testing for diagnostic purposes is mostly used for research and public health investigations. Lateral flow tests basically consist of a nitrocellulose membrane, antibodies, and labeled antibodies. When a sample is added, the sample will flow along the test device, passing through the conjugate pad into the nitrocellulose membrane, and then onto the absorbent pad. The sample pad acts as the first stage of the absorption process, and in some cases contains a filter to ensure the accurate and controlled flow of the sample. The conjugate pad, which stores the conjugated labels and antibodies, will receive the sample. If the target is present, the immobilized conjugated antibodies and labels will bind to the target and continue to migrate along the test. As the sample moves along the device, the binding reagents situated on the nitrocellulose membrane will bind to the target at the test line. A colored line will form, and the density of the line will vary depending on the quantity of the target present. Some targets may require quantification to determine target concentration. This is where a rapid test can be combined with a reader to provide quantitative results. The sample will pass through the nitrocellulose membrane into the absorbent pad. The absorbent pad will absorb the excess sample. The specification of the absorbent pad will have an impact on the volume of sample the test can incorporate. This test can tell you if the patient has type A or type B, but not the type of strain they are infected with. One of the primary benefits of using such tests is the quick turnaround time they provide, which is especially important for ED patients and children. The test results can help determine whether or not the patient should be admitted into the hospital. There are also semi-automated point-of-care assays that can be used for testing. This is a picture of the BD Veritor Flu A and B. It is manufactured by Becton Dickinson. The testing platform is a chromatographic immunoassay for antigen detection. It is classified by CLIA as a moderately complex test. It boasts a greater than 91% sensitivity and specificity when using nasopharyngeal swabs. It also allows testing of a wider range of specimens, such as nasal, nasopharyngeal, aspirates, and washes or lavages. Treatment for routine cases of influenza is primarily palliative care. This consists of at-home bed rest and over-the-counter analgesics to relieve body aches and clear sinuses. Hospitalization may be required in severe cases to maintain a patent airway or when the risk of organ failure is apparent. A widely underutilized treatment option is use of antiviral medications, some of which may be used to effect a decrease in viral replication. For example, NA inhibitors such as oseltamivir, which is Tamiflu, and zanamivir, which is Relenza, inhibit replication of both type A and B viruses and are non-toxic. In order to reduce the severity of illness and hospitalizations, antiviral medication should be administered within 36 hours of the onset of symptoms. If antiviral medication is given to the patient's family, a practice called post-exposure prophylaxis, transmission can be reduced by as much as 80%. For pregnant women and at-risk populations, post-exposure prophylaxis can reduce mortality by up to 50% if administered within 2 to 3 days of symptoms. Vaccination is the method of choice for infection prevention. Unfortunately, vaccine production requires months of lead time. This necessitates predicting the virus strains most likely to cause infections the following year. To inform vaccine updates, laboratories that contribute to the World Health Organization's Global Influenza Surveillance and Response System monitor the antigenic phenotypes of circulating viruses all year round. Vaccine strains are selected in anticipation of the upcoming influenza season to allow adequate time for production. A mismatch between vaccine strains and predominant strains in the flu season can significantly reduce vaccine effectiveness. Models for predicting the evolution of influenza based on the relationship of genetic mutations and antigenic characteristics of circulating viruses is used for vaccine strain selection decisions. Vaccines can be trivalent, which contain 3 strains, or quadrivalent, containing 4 strains. Both incorporate inactivated virus that is cultured in eggs. New research is being done to develop a universal influenza vaccine that would be independent of strains and would focus instead on a portion of the M1 or M2 proteins, which are more consistent from strain to strain. Measles and mumps both belong to the family Paramyxoviridae. They are both considered to be diseases of children, although adults can be infected. Measles has been around since at least 11,000 BC, with the first clinical description in 3000 BC. The first successful live vaccine wasn't developed until much later, in 1962. Mumps emerged a lot later, around 500 BC. The first vaccine against mumps contained inactivated virus and was developed in 1950. A live vaccine was later developed in 1967. The MMR, or measles, mumps, rubella, combined vaccine was licensed in 1971. Prior to this, children were given 3 individual vaccinations. In 1988, recommendations were made for a second booster dose to be given. It isn't necessary to memorize this picture or even all of the surface proteins, just the following 3: H, M, and F surface proteins. These surface proteins bind to host cell protein receptors. The H, or hemagglutinin protein, allows for host cell surface receptor binding and facilitates viral attachment and subsequent entry into the host cell. The M, or matrix protein, is a structural component of the virus. It is required for viral assembly in the host cell. The F, or fusion protein, mediates cell fusion, hemolysis, and also viral entry into the cell. Measles is a disease of humans only and is not spread to or by any other animal species. The measles virus is considered to be the most highly infectious virus known to infect humans and is readily transmitted person to person. Transmission occurs by infected aerosols and droplets generated by coughing or sneezing that enter through the eyes or respiratory tract, particularly the nose. The virus lives in the mucus of the nose and throat. The measles virus can live for up to 2 hours in an airspace where the infected person coughed or sneezed. If other people breathe the contaminated air or touch a contaminated surface and then touch their eyes, noses, or mouth, they can become infected. Measles is so contagious that if one person has it, 90% of the people close to that person who are not immune will also become infected. An infected individual can spread measles to others from 4 days before the typical rash appears through 4 days after. During the initial stage of infection, the measles virus attacks and destroys the cells lining the respiratory tract and the conjunctiva. It then moves on to the lymphatics. Once it becomes established in the lymph nodes, it affects cellular immunity by attacking T cells and mononuclear cells, releasing virus into the blood where it can gain access to most epithelial cells of the body. Measles can also affect humoral immunity by causing an overall decrease in antibody production. This can persist for months after the infection. The combined effects on both the cellular and humoral immune systems weaken the body's ability to respond to other antigens. This results in a temporary immunosuppression. This is the primary reason why there was such a high mortality rate and occurrence of superinfections prior to the availability of the MMR vaccine. There is a strong correlation between the incidence of childhood diseases and measles infection. It has been shown that prior to the MMR vaccine, contracting the measles virus also put the person at risk for subsequent childhood infections like mumps, rubella, etc., due to this dampened immune response. T cell response to the M or matrix protein is important in the recovery process. The rash that occurs is actually a result of both the cellular and antibody-mediated responses. It develops when T cells respond to viral antigen and antigen-antibody complexes form on the endothelium. This results in cellular damage and plasma leakage. Thus, the appearance of the rash is a clear sign that the immune response is in full swing. No rash, on the other hand, is a very poor prognostic indicator and may suggest that more severe complications are likely, such as pneumonia. The antibody response to infection occurs within the first few days of illness and peaks somewhere between 2 to 3 weeks. Measles antibodies will persist at low levels thereafter. Neutralizing antibodies are lifelong. Once the virus enters the body, it can take up to 10 to 12 days for symptoms to appear. Initial symptoms mimic the common cold: runny nose, watery eyes, cough, but in addition, a moderate fever. Complex spots may be visible during this initial stage along the upper roof of the mouth, back near the molars. If seen, this is diagnostic for measles. The initial stage can last between 2 to 3 days. The measles rash will typically appear following this initial stage. The rash is characterized by dull, blotchy red skin eruptions. In severe cases, the rash can be purple in color due to small subcutaneous hemorrhaging. Fevers generally spike over 38 degrees. Patients may also develop bronchitis or pneumonitis, crackles in the lungs. Internal lesions may also develop, appearing on organs and other internal structures. These do not always manifest any further symptoms, but, for example, development of diarrhea often indicates lesions in the gut. 2 to 3 days after this, the rash starts to dissipate and the infection begins to clear. Symptoms can be far more severe in children with malnutrition. Complications may also develop and can be severe. They include encephalitis, which occurs in about 1 out of every 1,000 cases, pneumonia, usually in immunocompromised patients, and death due to overwhelming viral infection. The mortality rate in developing countries is anywhere between 15 to 25%. There is no treatment for measles beyond palliative care. Therefore, prevention is the best course. A measles diagnosis is usually made by observing the rash or appearance of complex spots. Subacute sclerosing panencephalitis is a rare progressive neurological disease of children that may develop 2 to 10 years following the infection. It is the result of the virus attacking the central nervous system and occurs in about 1 out of every 100,000 cases. Most of the symptoms are limited to the central nervous system and the retina. Symptoms include personality changes, poor school performance, progressive cognitive decline, development of muscle spasms, and motor dysfunction, including loss of coordination, tremors, and eye problems, including blindness. Symptoms progress over approximately 6 to 9 months, at which point the child ends up bedridden and stuporous. The autonomic nervous system may become severely impaired, leading to death. There is no treatment. A measles diagnosis is usually made by observation of the rash or appearance of complex spots. Laboratory tests are not usually required or performed. However, antibody titers can be performed for IgM and IgG. They are usually done to determine immunity after vaccination. They can also determine acute and convalescence periods of illness. but the rash is the usual indicator. If a measles diagnosis cannot be made based on clinical presentation, the virus can be tested for by PCR. Acceptable specimens are a throat swab, urine specimen, or nasal swab, in that order, best to least. Like measles, mumps is a human disease with no animal or insect reservoir or vector. It is also primarily a disease of children. The virus enters the body via the respiratory tract. Symptoms do not appear until approximately 2 weeks following exposure. There is only one serotype. The most prominent symptom of a mumps infection is the painful enlargement of the parotid glands, which is often accompanied by fever and fatigue. Complications may occur and include testicular inflammation in males, which affects about 20%, but rarely associated with sterility. Encephalitis or meningitis may develop in as many as 8% of cases in the U.S. Deafness can result in a small percentage of these cases. However, most patients do not suffer any long-term consequences. This is a child with mumps showing the typical enlargement of the parotid glands. The immune response to mumps is typical. IgM production, followed by IgG, and some IgA, since it is infecting the salivary glands. As one might expect, IgG confirms long-term immunity, so reinfection is generally prevented. Incidentally, the virus can be detected in urine. This is due to dissemination of the virus throughout other organs. The diagnosis of mumps is often made by clinical presentation. The virus can be detected by PCR from saliva, throat swabs, CSF, and urine, which is relatively easy to collect. PCR is not typically performed for diagnostic purposes, though. EIA and indirect immunofluorescence can be done to measure antibody titers. Cell culture can also be done, but this is not routine as it is generally reserved for outbreak investigations. Rubella, or German measles, was first described in the 1800s in Germany, which is how it got its name. A large epidemic occurred in the US between 1962 and 1965 that resulted in around 12 million cases. A vaccine was developed in 1969 and is now incorporated into the MMR vaccine. Rubella was declared eradicated from the US in 2005, but still occurs in developing countries. As another childhood illness, rubella was considered relatively benign until 1941, when it was attributed to birth defects from pregnant mothers who were infected. Rubella is transmitted person to person and has no animal or insect vector or reservoir. Infections generally occur during winter and spring. The infection rate is high, but it has a low virulence. The biggest risk is seen with pregnant women, as the virus can cause birth defects. Many cases of rubella are asymptomatic, with only 30 to 60% of infected individuals being symptomatic. Mild cases may present with low-grade fever and upper respiratory symptoms, followed by the appearance of a rash. Unlike measles, though, the rash is faint and appears on the head, neck, and trunk. Patients may also experience mild arthralgia in all joints. Birth defects often develop during the first trimester and may include cataracts, cardiac defects, deafness, and physical defects. Some damage may not appear until months after birth. The incubation period is generally 2 to 3 weeks. Following initial infection, the virus spreads through the body via the bloodstream. Serum antibody titers peak around 2 to 3 weeks, IgM followed by IgG. Secretory IgA antibodies are also produced and will be present in the respiratory tract. Immunity is lifelong, but re-exposure may result in a respiratory tract infection without viremia or illness, along with a rise in IgG levels. Rubella cannot be diagnosed by clinical symptoms alone due to the length of time from infection to development of symptoms. ELISA assays are used for antibody titers, which can aid in determining whether an infection is recent or convalescent. If there is a need to diagnose an active infection, PCR is the best choice to detect the virus, usually from a throat swab. Testing can be performed for the following reasons: to determine the immune status of women prior to becoming pregnant, to determine the immune status following vaccinations, which is seroconversion, testing for acute infection during pregnancy, and testing on infants for congenital infections. The incidence of childhood disease and associated morbidity and mortality has dramatically decreased with the advent of vaccines. Increased immunity is achieved by vaccinating against all three at the same time, instead of individually, and the advent of the combination MMR vaccine has largely facilitated this change. In addition, recommendations published in 1989 stipulated that a second dose of the MMR vaccine be administered to further increase seroconversion. Unfortunately, we have seen a rise in outbreaks of MMR recently due to the failure to vaccinate children. In 1998, The Lancet published a fraudulent paper authored by Andrew Wakefield. In his paper, Wakefield described the cases of 12 children who reportedly developed autism, bowel symptoms, or other disorders soon after administration of the MMR vaccine. He used the cases to support a competing vaccine. In 2010, the General Medical Council determined that Wakefield's research was dishonest, and the Lancet fully retracted